Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director of Clinical Education and Partnerships at SICA, where we partner with providers to offer body composition solutions. Today, I'm joined by Linda Gigliotti. She's a registered dietitian nutritionist from Southern California, and Linda's a medical weight management expert in interdisciplinary weight management. She spent over 20 years at the UC Irvine campus in California, and she and I know each other really well through all of our work with the Academy of Nutrition and Dietetics Weight Management Dietetic Practice Group. So thanks, Linda, for joining.
Thanks, Nina, for having me.
I wanted to talk to you today, especially because there was a new paper put out by the Academy of Nutrition and Dietetics Journal, and it's on the incretin-based therapies or the anti-obesity or obesity medications, GLP-1s. There's lots of different words that are
Right.
going around about this newish class of medications that are helping people with obesity and diabetes and so many other health conditions manage their weight, manage their body composition, manage their food noise, and their relationship with their other health conditions. And so this paper came out about the evolving role of the registered dietitian in obesity care. And I thought it would be a really good chance to talk to our audience who many are dietitians, many are physicians or advanced practice providers, patients. We really have a kind of wide array of people who are interested in continually working towards better outcomes in healthcare. And so I'm a huge dietitian promoter. I think the work that we do is really fantastic. And I know that one of the things we'll get into today is kind of the role of the dietitian, what we know, and where we can pull from some of our own past experience to be really effective in this area.
Definitely. I would say going back about a year or more, the Academy realized that the use of these GLP-1s, incretin-based therapies, obesity medications, again, the names keep changing, but realized that this was I don't want to say hot topic because it's really more than that.
Right.
But was impacting obesity care and the role of dietitians. And there hasn't been a whole lot of guidance on that, and yet the public has embraced these medications very quickly. So the Academy put together a work group, and we published a statement, and then more information, and ultimately led to publication of this article in the fall of 2024, focusing on what we know and the role of the dietitians with these obesity medications.
And it's a really great place, I think, to start to maybe let's dive into kind of what the article attempts to do and who it's really for, because I do know that, each day when we're looking at the news and the media, there's so many different stories around, how people are accessing or not accessing these medications, and who are the right providers. I know in our community, we're really always talking about an interdisciplinary, comprehensive team. We really understand that obesity is a long-term chronic relapsing condition that affects someone forever. And so there's very little from the people I know and trust, there's very little focus on it being short-term, temporary treatment just for now. And so we can sometimes evaluate some of the programs that are popping up that seem too short term, too much of a quick fix, kind of a money grab, in my
Yeah.
opinion. But for people who want and need help in this area, it's hard to decipher who to trust, what's the right company, what's the right medication, and all of that. So I do feel like kind of coming back to our strong basis in evidence-based care and nutrition, that we can really kind of point people in the right direction to a registered dietitian on a team who's going to help somebody in this area.
Yeah, I think drawing from my experience with medical weight management, intense therapies, I certainly can appreciate and advocate support for the role of the registered dietitians and other health professionals working together to support our patients with these chronic diseases. But, looking at the scope of the article, I think we felt it was important to start out explaining, well, what are these medications? Everybody refers to new, but really, it's been 20 years. Exenatide was first approved for treatment of diabetes in 2005. And then there have been other of these incretin therapies developed and approved over time. Currently, 5 of them are approved for treatment of type 2 diabetes, but
Mm,
3 of the exact same chemical formulations, medications, are approved for treatment of obesity. Different trade names, maybe slight difference in dosings, but the same makeup of the medication. So we have some experience with the use of the medication. So
mhm.
if we can kind of shift what we've learned from diabetes care with these medications and then apply it to obesity care, I think we have some information to draw on. But you hit on an important point, and that is accepting that obesity is a chronic disease. So I don't refer to these as weight loss medications.
Right.
They're obesity care or obesity management medications. They're another tool in the toolbox in my mind. And they're going to be around. There's additional medications in the pipeline. It's kind of exciting to see what else is coming. But there's definitely a role for dietitians. I know I read a comment on one of the email list I'm on saying, well, doctors are prescribing the meds. There's nothing else for the dietitians to do. And I was
Mm,
like, whoa, wait a minute. A prescription is not quality obesity care.
right.
Lifestyle and foundation is the lifestyle and diet, physical activity is the foundation of all interventions for most every chronic disease that I can think of, and that includes obesity. So the focus on physical activity, diet, lifestyle is not going to go away, but it may need to be modified a little bit with what we advise, how we counsel
Yeah.
our patients on these medications.
Well, I think it's interesting too, the way that we frame all of this is very nuanced and it's so hard to get it right, especially in the media. But as we talk, in the past, I feel like we definitely had a more maybe discrete bucket type of mentality, right? Where you had either or type treatments. You either had a,
Mm,
nutrition focused intervention, an exercise focused intervention, lifestyle, then you'd add medication maybe, and then maybe surgical. And they really, for a long time, seemed to be discrete programs, units, providers that would provide that care for you. And so I know that over the past several years, one of the things I've been really happy to see is that the lines are a little blurry from that in a good way, where surgical patients may have medication added on board.
yeah.
Medication may help prepare a patient for a certain amount of weight loss prior to having surgery.
Mhm.
All across the board, we're talking nutrition and behavior. And I think one of the things that the public or the media kind of gets wrong, and just like what you said, it's, oh, they have a medication so they don't need nutrition anymore. We have this bias that's a really long-term deep-rooted bias we could talk about probably for a whole hour, or longer, but that it's like ethically good or right or righteous to have to like do the dietary things to lose the weight on it on your own. And people really hear that language from others about, oh, you took the easy way out, you're not
Yeah.
doing it on your own because you didn't use only willpower or some sort of rigid dietary strategy to lose the weight. Whereas I view it much more from a holistic sense of, if they need surgery or medication to get a head start, to get a larger amount of weight or excess adiposity off their frame, to be able to do the nutritional, behavioral, movement interventions that they mostly have learned over the years and are able to implement because their body is smaller and they're able to move better and they're able to have less food noise and be able to kind of focus on those things. That's a win for everybody. So it's not an either or, it's this really kind of both and kind of approach, don't you think?
I do. I think maybe a hard thing for some of us to accept is that um, diet and exercise, and I'm going to say food plan and exercise, are not enough for everybody. They're part of the regimen for everybody, but they're not enough for
Mhm.
everybody. So, one Criticism that I hear sometimes with the medications is, oh, I'm going to have to take it forever. Well, I don't know if you're going to need to take this medication or a medication forever, but I do know that chronic diseases like obesity require long term intervention. So the medication is not a cure. It's a tool, it's a treatment, it's an intervention. And as we work with chronic disease, we're going to pull different tools out of the toolbox, and different interventions to help a person manage their obesity and chronic health problems long term.
Totally. Yeah.
Taking a medication for obesity may mean being able to take fewer medications for management of diabetes or hypertension or whatever. So we look at that whole person.
Right. And I do think that's such a question that I hear always is,
Yeah.
well, I don't want to take medication forever, or, that just the idea that I'll take it, I'll lose some weight, I'll learn the things to do, and then I'll sustain on that, knowledge and education. And it's just funny how much we really do have a lot of research in the, behavioral realm and education realm, that just knowing what to do is not good
Isn't
enough
enough.
to do it long term. I mean,
Yep.
most everybody can understand that from their own personal lens, that just knowing the right or correct or good things to do, none of which I believe in any of those terms, but just knowing sort of what to do does not guarantee that you're going to do it. And
There
so,
isn't a person I've worked with over all my years who hasn't known what they should be doing.
yeah.
It's putting it into practice in their own lifestyle, in their
Yeah.
own unique manner. That's the challenge.
And I think, again, in my years as a dietitian with some behavioral background and understanding, I think that's been what's so rewarding about working with patients and clients who, when you're able to kind of hit on the stuff that they know and figure out how to help them integrate it into their current lifestyle, that's the sweet spot. And
Yeah.
it's really, rewarding to see people be able to get to a healthier place with those strategies. But, just like therapy or just like long-term management of medication, you need to keep that therapy going, to keep everything, with the outcomes that you're hoping to see. And that even
Yes.
is not a guarantee.
So, Nina, we kind of look at the role of the dietitian. I see two, two main objectives for our role, and the first really has to do with getting on the medication administration, helping the patient tolerate the medication. So you hear all the wonderful data about the meds, but if our patients can't stay on it, if they can't tolerate it, they're not going to get the results. um, so, I mean, there certainly are some barriers, and we know cost and access are barriers, but let's assume for a minute that our patient has the medication. Well, do they know how to administer it? These are injectable medications. Who's training them to self inject the medication weekly? Who's assessing that? Some of the medications are now available in a vial. Who's training them to draw that up? Again, I think those dietitians who've worked in diabetes are comfortable with that. But for dietitians who haven't worked with the medications, that's a skill that they may need to learn or at least be comfortable with. So if they're not teaching the patient, they're at least being able to assess and ask the patient questions about their administration technique. And then there's side effects. When we look at the real world, not just the clinical trials where there were, I think, up to 10% or so of people experiencing side effects, but real world, we're seeing up to 30% or so experiencing side effects. Most of the side effects are gastrointestinal tract. And I'm thinking, yay, dietitians, we know what to do with the GI tract.
Yeah.
That's an area of expertise. But um, being aware, nausea, vomiting, diarrhea, constipation are the more common side effects when they're experienced. They're experienced typically at the initiation of the medication. So when it's injected, they're transient, they tend to decrease. But that medication's injected every week. Some people are going to have a little bump in side effects when they have that injection. The
Mm.
protocol for the medication is to bump up the dose, start low and bump it up generally every 4 weeks or so. So sometimes when there's a dose increase, there's side effects return again, usually transient, but being aware of that,
Mhm.
educating our patients that they're transient, but here's what you can do to minimize those side effects. Small, frequent meals, staying very well hydrated is important, lowering the fat content, that these medications slow the GI tract. So if we can reduce fat, eat smaller amounts, it helps with that. Avoiding spicy foods. I mean, some of the very practical things that we all
Mhm.
know, but getting that information to our patients in a timely manner so that they don't become discouraged but can make some modifications to help tolerate the medication. I think also being aware that not everybody needs to go up to the highest dose of the
Right.
medication. You know, I talked with a patient last week who had gone up one increase, and she says, I'm perfectly happy losing my 2 pounds or so a week. I can tolerate. I don't have any side effects. I don't need to take any more. And
Mhm.
having that conversation with the patient is often the role of the dietitian, because sometimes they are prescribed such a that, like, well, come back when you need a higher dose. So we want to be there to be able to support the patient with
Yeah.
the um, getting on the medication and staying on it.
I talk a lot too, when we talk about looking at the body composition of somebody, a lot of times our healthcare providers are asking, like, how do I use that data? And a lot of times we're looking at the new patients, maybe where we kind of assess their body composition to start. And somebody who has a lot more fat free mass and is able to, lose a little bit of that along the way with significant weight loss, that's a very different patient than someone who starts with pretty low fat free mass and low muscle mass, where you want to be maybe
Yeah.
a lot more careful about titrating up medication,
Yeah.
and maybe they don't get to that highest dose because we're wanting to make sure that they're doing that in a healthy way. So again, I think that's another role of dietitians in looking at body composition data as people are changing weight and changing body composition over that, several weeks to months time point of finding that, medication sweet spot even.
Yeah. Well, and you bring up really I think the second role for the dietitian, and that has to do with our counseling for the long term.
Hmm.
You know, traditionally, when a patient's referred to us for weight loss, oh, we talk about a reduced calorie food plan. You know, we outline structure, and that is shifting. We often need to refocus when we're working with these patients, because the medications can have such a suppression on the appetite that they're taking in a significantly reduced calorie level. In fact, sometimes we need to actually work with our clients to take in enough calories.
Yeah.
And that's a shift in our thinking. If we're still thinking, okay, they're coming to us for weight loss or they're taking the medications for weight loss, we tend to go right to that reduced calorie food plan. So I think it's more important to be able to step back, look at the person where they are,
Hmm.
um, get a sense of what they are taking in. Do they would they benefit from some advice on calorie level, or is it more about the quality of what they're taking in? And again, I'm going to come back to chronic disease. What do we want long term? This is a perfect opportunity to work with our patients to begin to establish and put in place those food habits for long term health management. So, you know, are they consuming fruits, vegetables, whole grains, legumes, nuts, lean proteins, and so forth? You talk about body composition, and one of the nutrients we know is particularly important with weight loss, and maybe especially with the intensive weight loss that we see with the GLP type medications, has to do with the level of protein
Hmm.
that they're taking in. You know, we
Absolutely.
don't have a whole lot of research yet, because use of the meds and defining nutrition requirements is newer, but definitely we want to make sure they're taking in the RDA of zero 0.8 grams per kilograms, but often see recommended in the range of 1.2 to 1.5 grams of kilogram of protein per kilogram. So looking at what they're taking in, particularly if their appetite is suppressed, helping them to spread their protein throughout the day, 3 meals and snacks and so forth, to make sure they're getting enough protein in, to protect some of that lean body mass, muscle mass.
Yeah, well, and I think it's an important lesson that those of us who've been practicing for a long time with patients who have the chronic disease of obesity really understand, which is up front, there's a lot of discussion about, what's the amount, what's the recommendation, and what's the goal. Like, what people want to know, like, how many grams a day do I need, and do I recommend to a patient? And I always think that that's so funny, because sort of what you're saying is, we're noticing, maybe like bariatric surgery, metabolic bariatric surgery,
Yeah.
that their appetite's low and they've not
Yeah.
experienced that for a long time, many patients. So it's a good thing for them in their mind. And they're like, I don't want to
Yeah.
have
I don't want to
this
eat.
big
Yeah.
appetite. I have low, food noise. I don't have a lot of thoughts and obsession about food as much as I maybe used to in some patients. And so in those situations, we want to kind of balance that, like, these may be exciting things for a patient to have a little bit of a break from that, but we also want to balance that with enough and good nutrition. But the reality of working with the humans that we all are, and that that we work with, is that it's a dance around, what are they able to do, what do they like, what do they want, what do they have, access to. And I think that's a really fun place to be, where they're not dictated by an over active appetite, where we're saying restrict and pull back.
Yeah.
That's never been the type of dietitian that I was
Right.
in practice. It's like, what do you like? What do you want? How can we fit that in? And for, my history with surgery patients, a couple bites filling you up, like, that's great. That's some, so it doesn't have to be some perfect, balanced, protein. It can be things that people like and want to eat, and they're able to see success on that and feel full. And that's fantastic.
Absolutely. I think we're working to adapt and meet the patient where they are,
Yeah.
and if it's quality intake, that's the important thing. Nutrient dense
Yeah.
is, when I say quality, nutrient dense intake, because they're not taking in generally all that much. So that's the opportunity. You mentioned food noise. Perfect opportunity for us to work with the patients, because they tend to be far more receptive to making those adaptations in their intake when they don't have the intense cravings, or food noise.
Yeah. And they may have, my experience with patients who had surgery was that they've been waiting to do all the stuff they've been reading about, learning about, and having people sort of tell them what to do for the,
Yeah.
that, like, I had a lot of times where I had to check my own bias about going in and talking to somebody from, like, okay, let's talk about nutrition 101. No, this person has had a struggle with their excess adiposity their whole life. They know more about nutrition than I do.
Yeah.
They just have these other things getting in the way of being able to do it. And it may have been their biology. So even if, we go in and have this bias, like, oh, they just don't know what to eat,
Yeah.
I think that's a real miss. And so I appreciate kind of having, papers like this and guidance like this from our professional organization that put all of that out there, and show how complex it is. And a lot of times the stuff that we're really able to help our patients with is not even exactly nutritional. It really is accessing the stuff that they already know from an education stance, and being able to help them put it into practical daily use, along with a biological help from a medication.
Yeah, as we said earlier, it's not about knowing. So, you hit on the word practical. So, yeah, we have to look at, cultural background, socioeconomic level, where do they live, what's their lifestyle, their work style, other people in the household, et cetera, et cetera, et cetera. But all those other things that are going to impact their food consumption. And then look at willingness. What might you be willing to modify in this intake? Oh, you don't have breakfast or lunch? would you be willing to consider a snack, sometime? What would you be willing to have? What's the likelihood of being able to do it? Making it practical
Mhm.
for the person. I think also a part of our role is to help them with the psychological
Mhm.
component of weight loss, changes in body image, discussing expectations. Realistic, are they realistic? Does the person have realistic expectations of what this significant weight loss is going to mean? Very often I found that when a patient has experienced significant weight loss, they aren't quite used to who they are and how they relate to other people, and that can come as a surprise. So I think really that is part of our role in
Yeah.
supporting our patients for those positive outcomes in the long term.
Yeah. I mean, that sort of kinesthetic awareness is big, and where they're able to how they're able to move in their new bodies. There's a lot of that, and a lot of ways that we can interact with our exercise professionals and our behavioral mental health care professionals, who are able to kind of take, when we see something that's more than just a kind of a small issue, be able to take and work with them in that direction. And then I think another piece of that is, I know for me, for years, one of the best parts of my job was really being able to talk to patients who had significant weight loss about how it's more than just about weight,
Yeah.
because for most of our patients, they've been struggling for a long time. um, and they've got a lot of history of different people in their lives telling them different things, and
Mhm.
shame and blame, and all of that, and their own personal story with their body size. I think it's been really nice to be able to say, we now also have other ways to assess how you're doing, and we're not all just focusing on weight loss, which is why I think our language has
Yeah.
changed significantly. We're all, I think, uncomfortable saying weight loss medications. We're uncomfortable saying like weight loss surgery. This is the outcome. We know that it has far-reaching health
Yeah.
implications, and I think that's really, for me, also one of the biggest things I'm excited to see is people using a medication that has maybe weight loss and reduction in adiposity as an effect or a side effect or an outcome, but really the holistic focus on, hey, for sleep apnea or for heart issues, like we're
Yeah.
actually seeing the indication for this medication be not obesity alone, but obesity in the realm of a holistic approach.
Well, and that's, I think, so exciting when we look at this category of medications, the potential that they have. But you bring up a good point that one of the roles I think we have is to advocate and speak up. Look at approval for medications and how they're labeled, by the FDA, because if they're only labeled for weight, then we kind of miss out on having them approved, covered, I should say,
Yeah.
covered, for other diseases. So when we have the chance to comment to do that, please comment on regulations, do
Yeah.
that, and advocate. For the language and the role of the dietitian with these medications.
Yeah. I think it was promising that both Eli Lilly and Novo Nordisk kind of dropped the specific BMI criteria around the indication for medication. So now it's indicated for people with overweight or obesity, but not defined by the BMI
Right.
criteria, which leaves a little bit of kind of responsibility back to the healthcare provider to say, I know my patient has this disease based on these metrics, whether it be other health conditions, whether it be their body fat percentage, or their kind of medications that they're needing to keep other
Right.
diseases at bay. And that's kind of putting a little bit of that responsibility or power back in the hands of the providers, and not just the insurance companies, though they
Right. I mean,
they
we
may
know
have
there's
varying
problems
responses
with
to that.
BMI, only being BMI being
Yeah.
used to define.
Yeah.
Um,
The other thing, Linda, that I really like about this paper, and sort of from the academy's perspective, is just there's so many times that I encounter other providers who don't exactly know what a dietitian does. There's a lot of talking about bias. There's a lot of bias about, oh, you're an RD. you're going to come in and tell someone what to eat or give them a
Yeah.
meal plan, or just be very rigid in the approach. So again, I really like this paper and some of the other resources to really highlight the varying ways that dietitians can be a support on the team. So it's not just telling them, how much protein to eat. It's really kind of helping them in all these various ways. And I think this does a good job with that.
Well, to that point, I really have to encourage every dietitian to relook at their scope of practice. And if they're working more and more in obesity care, to look at the scope of practice, and both in adult weight management, but also in diabetes care and education,
Mm.
and kind of check off, where are you at the competent level? Where are you at the proficient level? Where might you be at the expert level? Or what do you need to do to increase it? And then speak up, because going back to one of your initial points, when we can work in an interdisciplinary team, then we really need to be practicing at the proficient and expert level, and we can bring so much more to the team.
Mm.
So get the training if you're not comfortable with it. Enhance your skill set if to take on more of a leadership role, really, with this management of our patients in obesity care.
That's a good point. Yeah. And we do have, from the academy, we have resources, we have education, we have a credential, the
The CDR
CSOWM,
has the credential
CDR.
CSOWM, Certified Specialist in Obesity and Weight Management. So take a look at that. If you're spending time working in obesity care, get credentialed in it and speak up and give yourself, that kind of credibility that you're an expert in that
Yeah.
field.
It also, this is, I know we want to kind of wrap up, but I do feel like it's another point that we're seeing so many entrepreneurial pop ups into this space. And it's reminding me over and over that everybody kind of has an opinion about what people should eat. And so, you know, there's a lot of people out there giving nutrition advice that is generic, not tailored to the person, very rigid, very, maybe self-serving from a supplement or a, you know, um, kind of personal connection to the products that they're recommending. There's a lot of that out there in this space. And once again, people with obesity are being taken advantage of because there's an opportunity for some folks to make money on it. And so I think, again, it reminds me how important it is that we speak up, for dietitians and what we do, but for the people that we're all trying to serve, and that it's not just a, quick fix, one size fits all thing. To really have a treatment for this long-term chronic condition, it's going to take the whole village and all the people to sort of
Yeah.
chime in and be part of that team. So I think we're making some good progress, but we've got some work to do in educating the general public, I would say, still.
We do. Well, thank you very much for the opportunity to discuss this. I will just highlight three webinars that the Academy produced
Please.
last year. And Lilly has granted an additional funding so that three more webinars will be produced this year, relating to various topics and obesity medications. The medications are free and available to all credentialed practitioners. So there is more and more information becoming available to support our role. Thank you
Yeah.
for this
And
opportunity to
they
discuss
do
the
a
art.
good job. They do. I would say, a lot of times people have a bias against, if it's funded by industry,
Yeah,
but really it's an educational grant and the
strictly.
webinars are high quality, but the commitment to the patient experience, and in that regard, from Lily in particular, I think is really strong and it's been impressive. So I'm happy to see that they're going to do some more in the upcoming year. I think that'll be great for our colleagues.
All right. Thank you.
Yeah, thanks, Linda. So if you want to stay in touch, I think the best place to connect with you is on LinkedIn and
That's
maybe at
right.
some of
I'm
our
on
professional
LinkedIn.
meetings.
Yeah.
I know that we're hoping to see a lot more, education in this space at Fancy, which is our big nutrition meeting
Yeah.
for dietitians. That'll be in October of this year.
Okay.
Great. All right. Thanks, Linda.
Thank you. Take care.
Bye.